Ladies and gentlemen, Dr. Richard Neugebauer is the Associate Professor at Columbia University, Director of Research in the Department of Pediatrics at Bronx Lebanon Hospital Center, Research Scientist at the Department of Child and Adolescent Psychiatry, New York State Psychiatric Institute. Dr. Neugebauer has published several articles on the history of mental illness, as well as articles and books on psychiatric and perinatal epidemiology, neuroepidemiology, and parasitism. I must say that perhaps about 30 years ago, I was also the graduate research assistant to Richard when he was doing a sleep study. So I have known Richard as my boss, and therefore I have no hesitation in still calling him my boss. So ladies and gentlemen, let's put our hands together to welcome Richard. Richard, so now the floor is open to you.
I don't know what title we finally came up with or were able to display for this talk, but it was the title as written initially was a little misleading. In fact, the purpose of my presentation is to use a survey that was conducted in Rwanda in 1995, which I happen to have access to because I worked in Rwanda during that period, actually and since. But that survey proves to be immensely helpful in terms of assessing to what extent placing children who have been orphaned in institutions or in orphanages is or is not a better solution to their crisis than placing them either back in their homes with their nuclear family or those family members who survived. So it's a matter of comparing using PTSD as a measure of mental health or lack thereof, rates of PTSD in orphanages as compared with rates of PTSD among children who were in fact returned to their homes in the course of and after the genocide. I hope that is clear, although I don't know how anybody will signal to me that it isn't. But that's the strategy for this talk. It's not really focused on the children per se, but using that information to test a specific hypothesis. And just to cut to the chase, can you all hear me? Yes? No? Maybe?
Yes, we can hear you.
Great, okay.
Thank you.
And of course, how can I advance? Hold on a minute. Okay. No. Yeah. At the present time, well, let me go back for a second. After World War II, John Bowlby, who was then the sort of preeminent child psychiatrist in Britain, was asked by UNICEF to put together an assessment of which was the better approach to handling children who had been orphaned. This is a quote directly from his let's remove the bottom, ignore the bottom part of this. Okay, is it now just limited to the top?
Yes.
Yeah, okay. So this is Bowlby. It is essential for mental health that the young child experience a warm, intimate, and continuous relationship with his mother or mother substitute. In institutions where the child has no one person who cares for him in a personal way and with whom he feels secure, brings in its meaning, being placed in an institution brings in its train acute anxiety, guilt, and depression, and then he also adds a little later on, aggression. This particular view of institutionalization has been accepted since Bowlby pronounced it. And the consensus currently among mental health specialists, psychologists, psychiatrists, those working in NGOs, is that institutionalization is to be avoided at all costs. That almost by definition, it is worse than any other placement that can be proposed or implemented. Here's an example, for example, from the 2007 Interagency Standing Committee for Guidelines on Mental and Psychosocial Support in Emergency Settings. This is a quote from them. Under these conditions, meaning the child's family or part of their family has been killed, placing the child in an institution should be considered a last resort. The results of these analyses, and actually it's supported by other data from Africa, is that this statement is actually the reverse of what should be the recommendation. I'll show that based both upon the data that we collected in Rwanda and also from other reports that have been issued since, it appears that either orphanages are either no worse than, or sorry, placing the person in the home is no better and no worse than placing the child in an institution. And in most instances, for example, where there's only one surviving parent at home, and then even more severely, where there are no parents at home, only other children, a child-headed household, the institution is to be much preferred. I'll skip over most of, well, here are some of my colleagues. Just by way of background, in 1999, I was invited by UNICEF to bring down a team of, or an international team, to evaluate some of the elementary trauma alleviation programs that UNICEF and the Ministry of Health had implemented in Rwanda. It was in the course of that visit or trip to Rwanda that I became aware of this unusual and really remarkable national survey that was conducted 1 year after the genocide. The survey, or the individual, the researchers surveyed 3,030 individuals ages 8 to 19 in each of the prefectures, which was the division. Those were the divisions that we used in Rwanda in that time period, since changed. And from each prefecture, they would identify one or more orphanages where they would interview some proportion of the persons present there. And also they would interview people living at home or living with relatives, let's say, but who live relatively close to the institution where they conducted the initial interviews. Okay. The interview itself had two elementary components. One was to assess individuals' exposure to traumatic events, and second, to assess their the children's psychological reactions to these events. I'll go through a handful of the events to give you some awful flavor of how violent and grotesque some of these acts of violence were. The psychological reactions are reasonably similar to DSM-5 or DSM-4 symptoms of post-traumatic stress disorder. And I will use those symptoms as a measure of the degree to which one placement or the other is more harmful than the other for children. Okay, that's it about. Okay, measures, I've already covered this. Just a very quick summary of the sociodemographic characteristics of the sample. Incidentally, from here on, I will exclude reference to sample 1. Sadly, when they completed their interviews with 1,200 individuals, they realized that they had incorrectly assembled the items measuring symptoms. So sadly, that whole portion of the survey is of no value in terms of assessing, symptom levels in that group. So from here on, I'll focus only on what I've called sample 2, which is 1,830 people. And given, let's just see. Let's move on to the next table, because I think it's more informative. Okay, this is a characteristic of the individuals in the survey. As I said before, they were ages 8 to 19, 49% were female. The mean years of education was 5. Most of these children had actually not attended any school at the time they were placed in institutions. The range was 0 to 12 years of education. Residential circumstances, UCCs, or what's called in context unaccompanied children's centers, or what we would call orphanages, I guess. 49% of the sample lived in UCCs, and the remainder lived in some community setting, either with both parents, one parent only, neither parent, but with other siblings in the household or other relatives in the household. There were other placements with relatives, with foster families, and that I won't be addressing in this particular presentation. This is typical of the questions asked and of the frequency of the events reported. Have you experienced death in your family due to war, meaning due to the genocide? almost 80% of respondents said, endorsed that item and said, yes, they had. If both, a third had had both of their parents killed. Have you witnessed with your own eyes someone being injured or killed? Did you hear people screaming for help? Again, about 80% of people reported that. Killings, injuries with machetes, about 60%. Rape, about 30%. Dead bodies or parts of bodies, almost 90% of individuals interviewed. And again, these are people ages 8 to 19, reported seeing dead bodies or parts of bodies. I'll skip, I mean, that I hope gives you a, I don't want to say a flavor, but it gives you a sense of how severe many of these traumatic exposures were. Then there's this particular item which has interested me and actually interested in the initial investigators who were working with UNICEF. About 15% of the respondents said that they had spent some time hiding under dead bodies. The UNICEF investigators had wanted to return to the schools and the UCCs to interview some of these children. That there was no opportunity later on to do that. But since I've done 2 subsequent surveys in Rwanda and asked the people in those surveys, I mean, people who were only by accident connected to this much earlier survey, we've asked them whether they spend time hiding under dead bodies, and we'll be reporting what their level of PTSD symptoms is subsequently. Here, again, I won't bother to go through all this, but on the left-hand side is the DSM-4 symptom criteria as stated in the DSM-4. And on the right side are the items, obviously they're in English, but they were in Kinyarwanda when they were used, that approximates actually reasonably closely the symptoms that were presented in DSM-4. For example, recurrent and intrusive recollections. The items on the Kinyarwanda instrument were think about event when you don't want to, pictures or memories of the event suddenly pop into your mind, heard or saw things that make you think of the event, and so on. This, of course, I can't see your expression, so I don't know whether you're agreeing with my characterization of this or not. But from our point of view, it appears as though the symptom measure used in Rwanda provided very adequate coverage, actually about 90% coverage of the symptoms that had been reported or used in DSM-4. So we're comfortable both with the fact that the measures of exposure were, they were awful to read, but at least they provided very extensive coverage of what the children might have been exposed to. Similarly, the symptom coverage seemed to us adequate. Let's skip that. Just to anticipate what I'll be concluding, just 1 minute, at the end. Bowlby was the, as I mentioned before, preeminent child psychiatrist in the 1950s and 60s. Michael Rutter, whom you could say has a parallel status now and has had since about 1980. This is a quote from an article that he was an author of, which states the exact opposite position that Bowlby had stated. It's a little inelegantly expressed, but there is sufficient evidence available to reject the view that institutional care is necessarily always worse than community care. He might have, or they might have gone on to say that in fact institutional care is in many situations far better than community care. But that's where we will get to, I hope, in a moment. This is just a comparison of the UCC and the children who are living with family members. Again, there isn't really time to go over this, but briefly, as we would expect, it was the children placed in institutions were predominantly younger children. You know, this is 35% were between the ages of 8 and 10, about half, almost half were between the ages of 11 and 13. And then the reverse was true for people living with families. The great majority, I mean, very few actually, were below age 14. Most of them were older. And I will, as you'll see, we will adjust for that in the comparisons that we put forward. The genders were roughly evenly distributed. Just as an aside, this this finding is not true of interviews we've done with adult populations, where in certain sections of Rwanda, the one I've worked in, 75% of the population were females because the males had been killed in the course of the genocide. Education, again, people in the UCC, living with families were far better educated than the children living in UCCs. And in fact, the children in UCCs were barely educated. I mean, 60% had virtually no education at all. This is not the right slide. Okay. Quickly, the rates of, I think we have about 7 minutes left. That should be enough time, I hope. The rates of disorder, or PTSD, we didn't actually measure PTSD, we measured symptoms, and then we had a cutoff that had proved useful in some other studies, and in this one. So when I say rates of PTSD, I really mean the rate at which the sample scored above a certain cut point, or the proportion scoring above that cut point. As you can see, the rates of PTSD by age in the UCCs, I mean, it's inverse. Well, it's not inverse. Let me scrap that. It's actually not particularly, it's relatively uniform across the age groups. This 63% should be ignored. I mean, it's only 7 people who are the basis of it. Similarly, the rates of PTSD did not differ dramatically within the UCC children. This 75%, again, like the 7% down, like the number 7 here, does not really contribute much to the variance in this table. Male and female, we'll skip. Okay. Now let's get to the central part of this. Just 1 second. Okay, this table displays the unadjusted rates of PTSD in the 2 groups. And as I think should be relatively plainly seen, even without adjustments, the rate of PTSD among the UCC children, with the exception of this small group here, the rates were in fact lower than the rates among the children living with their families. So here among children, oh, sorry, that's a mistake. Scrap that remark. Yeah, this has been mislabeled, but you'll have to take my word for it. As you'll see in a moment, I think we actually have an easier slide to look at. The average number of traumas reported by the children were significantly higher among the children in the orphanage than among the children living with families, which makes the fact that at the end of the day here, you'll see that the rates of PTSD were higher in the family group. The fact that the exposures were much higher in the UCC group would have worked against this finding. In any case, here there are among both the orphanage children and the children living with their families, there were individuals who were single orphans, meaning having lost 1 parent, double orphans, or both parents were alive. Now, what I mean here is that in the UCCs, even though they were so-called orphanages, there were children who had lost both parents, lost 1 parent, and a number of them, a non-trivial proportion of them, had both parents who were alive, but those parents had decided to place their child in the orphanage. We think because they immediately, or not immediately, but they understood that the orphanage would end up being safer for the child than would be living with the family in the household. Again, double orphans, the rate of PTSD in UCCs is 35%. But the people living in homes who were double orphans, it was 47%. Similarly, for single orphans, 42% or 43% versus 64%, and with both parents alive. Now remember, these are individuals who are living in a household in which both parents are present. Both parents survived the genocide. And yet, the rate of PTSD is substantially higher in the homes than, I mean, among the children in the homes than in the orphanage, which, as I said before, runs counter to the current sort of consensus that homes are better than UCCs. At least if PTSD is a measure of mental health, or obviously one measure of mental health, levels of mental adjustment or mental health was higher in the UCCs than in the families, even though the children in UCCs had experienced much more trauma. This is simply, let me just see, let's turn to this. This is a bit complicated for the last slide, but if we look, let's say we compare children with living in UCCs with 2 living parents versus children living in households where there were 2 living parents. The 2 groups were, I mean, the rates of PTSD in the 2 settings, meaning both living parents and the UCC versus the home, there was no difference in the rate of PTSD between the 2 groups in this adjusted analysis. There is this unadjusted, but that seems to me of little interest at this point. Where there was one family member, one parent out of the 2 who was deceased, and usually it would be deceased or had been killed during the genocide. Here, the rate or the odds of PTSD in the nuclear family was nearly 3-fold the rate of PTSD in the UCCs. Again, a very strong confirmation that the UCCs, rather than being, in this context, harmful, were in fact helpful, and an even more striking result if we look at children who had where neither parent was alive. Now, of course, the question is going to be, why do we find this result? Given the brevity of time that remains, 2 things. First of all, this is not, when you look at all the European studies, including some of those studies from Romania and other Eastern European countries, the pattern, the indication or the evidence condemns the use of orphanages as a place to sort of store or keep children. The African studies, the majority of them, do not support that finding. In fact, they report the reverse and agree with what I'm presenting here. And you'll remember that quote that I provided from Michael Rutter, where he himself says, the evidence is by no means convincing or universal or consistent that orphanages are harmful. It turns out in some settings they are helpful. And those settings are settings in which, well, first, it seems to be partly a pattern that emerges in the global South, but not in Western Europe and the US. Secondly, it seems to be the pattern that arises when the circumstances of the society at large, where social order and civil life or civil society has been effectively destroyed, which was certainly the case in Rwanda during and then after the genocide. So in that setting, it almost seems self-evident. The parents themselves were in such crisis and so overcome by all their losses, it appears as though they were barely able to parent the children who had survived. That was not the case with the people who were working in the UCCs and taking care of children there. Or if it was true of them, they were not living in the home in which those deaths had taken place. So these findings, rather than being, initially when I found them, I considered them counterintuitive and difficult to believe. They now, of course, like a lot of these findings, make sense. And I guess if I had read more about orphanages in the global South, I would have anticipated just this result. End of my talk. Any questions? Assuming I can't really see anybody, but.
Well, thanks so much, Richard. Any questions from the floor? Any questions online? Any questions from the floor? Richard, so the issue of the home, the home being worse off than the institution, what are the is there. Is it likely that the parents who are alive are acting PTSD out on their kids, and therefore it's better in institution than being with the parents? What is the real reason for that?
You know, of course, that the answer to that was not part of the evidence we collected, unfortunately. But first of all, what I learned just anecdotally is that initially the children put in the institutions, even when there were brothers and sisters in the same institution, because of the scale and the chaos initially, they were completely unaware of their siblings. After a certain point, it occurred to the staff that they should try to link them up. And they would post signs indicating the names of the children, although some of the children, of course, could not read. And so after a certain point, a greater level of sociality had developed within the institutions. Many of the children knew each other from beforehand and were free, relatively speaking, within the protected walls of the orphanage, which was important, to form close, relatively close-knit social groups. That's my take on it. And also, the parents, when there were two living parents, as I mentioned before, the parents themselves, in many instances, not trivial, in many instances, decided to place their children in the orphanage. I interpret that as evidence that they consider the orphanage a better setting for their children than the home. But we have no direct information on this. Let me add another point, though. The UNICEF group introduced some trauma alleviation methods in the UCCs. And so we expected that maybe the lower level of symptoms in the UCCs was in part attributable to the effectiveness of these UNICEF programs. In fact, we did an analysis of that and have published it. In fact, the UCCs where these programs were introduced, on average, those children had higher levels of symptoms. Still much lower than in the community, but higher compared to the children in other CCs where these types of programs had not been introduced. But I can't give you an informed answer to your question because we just don't have that information available.
Well, Richard, thanks so much for wonderful presentation during difficult crisis. Crisis, yeah. The research itself, and then crisis that we had to go through trying to.
It's okay. And William, we must talk one of these days.
Yes.
Besides this context.
That's correct. That's correct. I think it would be appreciated if you can share the full research with us, because it is an interesting topic. Unfortunately, we've run out of time because we had some difficulties and send the proper link to you. So Richard, on behalf of the persons who were online and the persons who were in the room, I would like to say a big thank you. And on that note, would like to bid you goodbye. So we speak again in cyberspace.
Let me say this: it was a great honor, actually, to have an opportunity to present this material where you are. So thanks are not necessary. It was just very rewarding by itself. Thanks. Take care, everyone.
Thanks so much, Richard. You take care as well. Bye-bye.